I'd like to thank the organizing committee for inviting for this short topic on how to assess the TR and the OR. I know it's the last session, so you might have heard the last few days as well as in the workshop. So just to summarize a few of the things. Close relevant to the talk, just to summarize, at the end of the session, I promised that we'll able to familiarize the most common views we use to assess the tricuspid valve, and just to overview on common causes for TR, so qualitatively and quantitative assessment with various modalities we use, and just to touch base when to address these situations. So the common views, obviously, we'll start with the 4-chamber, then you have RV inflow-outflow view, modified bicable view helps a lot of time, and then when you go down, we have a gastric, transgastric, both basal short axis as well as the RV inflow view. And additionally, in a couple of views, we may use in certain situations like modified deep transgastric and modified mid-esophageal long axis. Everybody familiar with this? So the only thing is you need to understand on the lateral side, you may not able to see all the time the same leaflet. It can be either anterior or posterior. It's a little bit challenged just to be understanding. So if you push the probe further deeper, we call it as like deep 4-chamber. So a lot of time you may end up in seeing posterior. And again, it's still uncertain. The second view is the RV inflow view. As you see in the picture, the medial part is again, either anterior or septal. This is a very common, I see in the residents, they always assume this is a septal, but not necessarily. It depends on where you are slicing, whether you are slicing at the septal or you are slicing at the anterior leaflet. The third view, modified bicable view, it helps a lot of quantitative measurements, as you can get the parallel Doppler in majority of the time. The fourth view is the transgastric basal view, and this is the one particular view where you can able to see all the 3 leaflets, and if you have a little bit of 3D knowledge, you can even measure the valve area in a much, much better way with this view. Then we do have the RV inflow view, which can be obtained in this particular angle. It helps to assess the papillary muscle, any dysfunction along with the leaflets. Then we have a deep transgastric. As I said, this is not a very common view we use, and obviously if you get an opportunity to get the skinny patients, you may have a better assessment of the Doppler again with this view. Obviously you have to rotate more towards the right. And then finally, mid-esophageal long axis view, it helps in some of the vena contracta, which I'm going to go through in the next few minutes. So that's about the different views, and just to summarize the various causes, the primarily a lot of time is going to be the secondary TR, not the primary TR, but when it comes to the organic disorders, it depends on where you're practicing. Particularly in our country, it's still rheumatic is pretty common, so that should be top in the list. And we do get our life expectancy is getting better. We may end up in seeing more and more degenerative disorders. Very rarely we see tumor-related, mostly like a carcinoid or malignant. A lot of time you also see device-related iatrogenic TRs, like either pacemaker or AICD devices can contribute. So the second TR is a classical example where you have a lot of the pressure or volume overloaded in the RV. That's going to increase the gradient between RV and RA, so that can contribute to TR, and most of the time there is no intrinsic valvular pathology, so that you have to differentiate. Obviously most of the time they will be having pathology on the left side. So this particular individual, he came for significant mitral stenosis secondary to a carcinoid, and then he ended up in having this secondary TR. It's the same individual where you can see in a different view And as I said, like you have a better assessment, and you can see a significant central jet in this particular situations. This is a classical case of the primary carcinoid disorder in the tricuspid valve itself. And as you see, there's a significant dilatation in the annulus. So that is your highballing. By itself, we can say there's something wrong, and and it's straight away you can go and reassess in few other views to, just to finalize your diagnosis. Is there another, the same patient with a different view where you can have you have a significant distortion in both the leaflets, and then you can see the kind of eccentric jet in this view as we don't see in the other views. And obviously, a lot of time the surgeon try to repair this tricuspid valve because once you address, they're going to use to the low pressure system. But unfortunately, when you have such a significant intrinsic pathology, even in a good hands, it's very, very less likely they will be successful to repair. So they end up in having replacement. So this is a post-TVR, and then where you can see almost like a residual leak across the valve. This is a classical example of a primary infective endocarditis at the tricuspid, especially in a certain drug abuse or any other source for infection, you tend to see mostly on the right side. So this is a classical example of eccentric. Unless otherwise you prove it in a different method, we always quantify this as a severe TR. And the same individual after the, this particular patient had actually combined mitral as well as the tricuspid. So he had a both mitral replacement as well as the tricuspid replacement, repair, sorry. So just to summarize, so this is the 4 views, and I showed a few examples of different causes. And the next part is about how you assess when you encounter in the TR, and these are the ways we can do, starting from TR jet assessment, both like a length as well as the area wise. You can measure the vena contracta, you can measure the secondary changes of the hepatic vein flow, and you can directly measure the tricuspid annulus as well as the RA dimensions. And very rarely we tend to do PISA calculations. A little bit time consuming, but if you are familiar with the MR assessment, the calculations are pretty much the same. So starting with the TR, and as the picture described, we can quantify grade 1 to grade 4 based on the length of the jet, starting from 1.5 all the way to the 4.5 centimeters. In terms of area, you can again use from anywhere between 2 to more than 10. The vena contracta is the second pretty common method we can use, and obviously you have to get as good as optimizing your color flow Doppler before you go and do actual measurements, and also try to get as parallel Doppler as possible. And it has a very good sensitivity as well as the specificity in terms of quantifying the TR. Of course, in certain situations, this may not be really helpful, especially in this particular example, where you can see such a distorted valve, and we don't know where to actually measure the vena contracta. So we need to be cautious in those situations. The secondary things, which is like primarily we are measuring some of the measurements of the tricuspid, so we can see the directional change, when you have a TR, obviously the backward flow into the commonest vein, which is the hepatic vein, which is relatively easy to obtain, parallel Doppler in majority of the time. Obviously, you have to go to the transgastric, rotate the probe to the liver, and then you optimize your vein, hepatic vein joining into the IVC, and get the parallel Doppler as possible. And this is the classical different waveforms, which is most of the time similar to the pulmonic vein flow. I'm sorry, yeah. But in only thing is you tend to see an additional vein, the V wave. So SVDA is the order where we tend to see this. So in a situations where you have a TR, you may have a moderate TR where you can see the blunting. In a severe TR, you can see even the flow reversal as it's shown in the two images. Tricuspid annulus, the most important thing is you should measure at the end systolic. So a lot of time I see a lot of people measure at the diastolic, but it always has to be measured at the end systolic where you have, the tricuspid annulus has an ellipsoidal shape and it's a quite dynamic situation. It turned out to be a circle when it become like, systolic, and that's the one way, to say whether it's significantly dilated or not. So if anyone having more than 34 millimeters, then it's a classical example of dilated tricuspid annulus. This is like a mediolateral dimension of the RA, but this has to be measured at the diastolic phase. And again, it's like anything more than 4.3 centimeters, I believe it's like usually associated with possible TR, unless you have any intrinsic right atrial pathology. The last one, which is not commonly practiced, but if you have an opportunity, if you are familiar with a lot of quantification in the MR, you can still use the PISA method. The only thing is different from the MR is like you should have the aliasing velocity should be around 28-30, not 40, which we do for mitral. So that is one thing you should keep in mind when you are doing this. And this example where you can see the PISA length is about 0.8, and when you calculate based on the continuity equation, you get the EROA close to 40 millimeters squared. So for that, you need to have peak velocity as well as the VTI across the tricuspid valve. Just to summarize, it's the same way of grading. The MR is equivalent to the same the TR with slight difference in the number, especially the PISA radius, where we see more of like here is like anything more than 0.9, which is slightly more than what we do for the MR. But rest of them, like especially the hepatic vein flow Doppler, like blunting or reversal, is pretty much the same. A few other measures. The only problem with the TR is there is no clear-cut differentiation between mild and moderate for most of these quantitative measurements. You can clearly say it's a severe, but if you want to quantify it, the only useful tool is the PISA radius. So that's the one thing we can able to differentiate, but rest of the measurements was unable to differentiate mild versus moderate. Just to stages, it's like a different stage. It's better for understanding how the patient was presented. It's more like a preoperative situation, whether they are on any long-term diuretics or any other heart failure measurements. We need to know. We have to always combine with that, when you are making the decision. It's just not the isolated, you are looking at the intraoperative TR, and then you can say straight away it has to be fixed, but is it meaningful or not? So there is a stage where it had risk becoming a progressive, and finally it will become like a asymptomatic to symptomatic. Then if it's a symptomatic, obviously it's a clear-cut decisions. The gray area is when it is becoming progressive to asymptomatic, is the controversial. It's a lot of times institutional preferences, and there's no clear differentiation of when to address the tricuspid valve. So this is the flow chart where you can see very less greens. Like, there is a clear class 1 recommendations for tricuspid repair. Only in 2 situations, in a symptomatic TR, which is very clear, which is like a stage D, they're going to have a lot of dyspnea, palpitation, any other, you may have an arrhythmias, then definitely your addressing the tricuspid is going to help overall perioperative outcome. The second situation is in asymptomatic but severe TR, then probably there is a role. But the rest of them are either 2A or 2B recommendations, especially like if you have a dilated tricuspid, then probably you should combine with the pulmonary arterial hypertension. So if somebody has a pulmonary arterial hypertension, even without dilatation, they say there is a consideration, it's a class 2B, but if there is a dilatation, obviously there's a clear-cut like 2A for repairing. The same thing, we put it in a different format along with the level of evidence. And again, you can see most of the evidence are either B or C. We don't have any class A evidence for this particular area. And stage C and D, if it's asymptomatic or symptomatic, definitely there is a role of addressing the tricuspid. So just to summarize, we have seen common causes and various views to obtain and some modification of the usual views in certain situations. And as I said, if you're familiar with a lot of MR measurements, it's pretty much the same, except like some aliasing velocity, you need to be cautious when you're using for PISA or EROA. And obviously you have to discuss with the primary team. It's like any other valvular disorder, have some dynamic changes intraoperatively, so that you have to keep in mind before we conclude whether it has to be addressed or not. These are the references I used. Thank you for your patient listening. Topic was 10 plus 5 minutes, but I didn't know that, so I just took for 15 minutes. So.
Any questions or comments?
This issue in patients who are undergoing CABG.
Yeah, so ischemic TR, like we have ischemic MR. So to my knowledge, I don't think there is any clear-cut differentiation of saying that this is because of the ischemic. But only thing is we have an associated RV dynamic changes we're going to assess intraoperatively as well as even preoperative echo. So by addressing right coronary, and if you see in reality, everybody will have either a stent, which is very rarely they will graft the primary right coronary, which is the proximal coronary grafting. So a lot of time we're going to have either a PDA grafting as compared to the proximal right coronary grafting. So by the time the blood vessels, when you're reaching the PDA, I don't think there is any direct effect on the tricuspids. Please correct me, all the senior professors, if I'm wrong.
So thank you for your fantastic talk. My problem is dealing more and more with these transcatheter procedures in tricuspid regurgitation, that the severe tricuspid regurgitation starts very early. And if you see these very severe sick patients, they have an EROR of 2.5 square centimeters. So even if you reduce that by half, you will end up in a severe tricuspid regurg. Do you have any clue for these situations in graduating the severe and very severe and extremely severe TR?
So the point is, like as you mentioned, it's not only the distribution, the area, but also how powerful, right? So when you have a significant gradient between RV and RA, the area may be less, but it's powerful, like hitting on almost on the wall. So we tend to see same thing on the mitral, but I don't think we use that as a specific criteria just by the area. So as I said, like we have to use the supplement, and then whether it's a symptomatic, preoperatively, whether we have any secondary changes like hepatic dysfunction or hepatic congestion. So that we should keep in mind before we address.
Okay, thank you.
Yeah, thank you. Thank you again.
How about low TR in failing RV? I mean, you don't get very big TR, but it is a severe abnormality there.
Yeah, it's like, we do a lot of VADs where we have associated RV dysfunctions. We tend to see this problem. But obviously, in those situations, we will be measuring real-time pulmonary artery pressures, like both pre-bypass and then, if anything changes, that we can keep as a guide, one thing, because you cannot just look only at the gradient or a jet across the TR. It's like any other, even aortic stenosis, we have poor functions, they're going to have a low gradient. So similar to that, you are going to see everything, all the measurements which I mentioned is going to be on the lower side. So, and if you know that there is a significant RV dysfunctions, that has to be primarily addressed before you go and see the, whether it's any definitive role of addressing the tricuspid valve. Yeah, thank you.
Thank you.